Shams. I'd like to keep the program going forward, and as a segue to our next talk, the title of my talk is going to be on statewide criteria for stroke center certification and designation. The reason this is so important is we're not standardized across the country working in the same way. And as you'll see in this talk, there's so many unique differences within each state in the United States, and this has significant implications on scale and pace of operational rollout of stroke systems of care within each of the states. So I just want to take some time to share this. These are my disclosures. I want to acknowledge Dr. Chandral Chugh and Dr. Shams for a lot of the research behind my presentation. The goals of my talk today are going to be to talk about stroke designation in more detail, statewide stroke legislation and how there are differences and how it's impacted us, statewide stroke certification and how they are relevant, and some lessons learned from heart attack and what we can do to learn from that and accelerate our growth. Starting off with stroke designation, why do we need it? Why do we have to complicate our lives with accreditation, certification, designation, legislation? And so the reason designation is very important is we've got third-party certifying bodies that certify hospitals as a comprehensive primary or stroke-ready facility. Each state has an ability to empower their cities, towns, councils, and EMS agencies to be able to redirect volume to different stroke centers. And at the end of the day, stroke centers grow because they want to cater to the community and they want to cater to the stroke patients in the community. And it makes a huge difference where EMS triaging happens to these stroke centers. So the success of the device industry innovating technologies and stroke centers succeeding and being able to be a successful unit requires EMS to be aware which facility has these exciting technologies to be able to provide the care in time so that the right stroke patients are brought to the right facility. And that's where designation becomes important. Ensure high quality care for brain attack patients, assist EMS in triaging stroke patients to appropriate facilities, provide state oversight of third-party certification processes, and comply with state legislation for stroke designation and triaging. Now, with regard to, we've got around 4,000 plus hospitals in the United States. How do we get all of them certified in some level, level 1, level 2, level 3, so that whether it's drug or device therapy, they are all over America, and no matter where your family member or loved one is at a particular time, and God forbid if they were to have a brain attack, then we've got the right facilities capable of escalating the treatment paradigm. So we've got hospitals that are not certified. We need to get them certified, and most states start off with self-certification where the CEO writes a letter. I've read the Brain Attack Coalition guidelines of 2005, and I write in this affidavit that we meet the criteria for comprehensive, or we meet the criteria for primary. That's how most states start. Then they go on to partnering with third-party certifying bodies like the Joint Commission, DNV, HFAP, to get certification to be able to scale up the certifying process. And to be able to accelerate this whole process, you need state legislation, and which is what I'm going to talk about. This is a map of the United States where we have 14 states that have enacted legislation to be able to designate stroke centers as level 1, level 2, level 3, and empower EMS agencies to be able to triage patients to the appropriate stroke center. And if you're from one of these 14 states, then you already noticed the impact of this. And so it's very important that we understand that stroke care across the United States is different, and growth in different states is different because of this. Now, this next slide pops 2 more states, and these states are where there's pending legislation to be able to enact stroke designation and triaging plans. These are the House representatives in different states that have actually passed House bills in favor of stroke care, and each one of these bills have been on empowering states and agencies to be able to provide stroke care, and each one of them, in my opinion, is a stroke hero and a stroke champion. These are the state senators across the country that have passed Senate bills that have gone on to empower states to be able to provide care. And if they're one of your state senators, please take note, they are a true stroke hero in being able to empower states. These are the 2 states in West Virginia and Massachusetts where there's pending legislation and Senate bills. In addition, some of these House bills and Senate bills go on to become very powerful acts. For example, in Georgia, Senate Bill 549 became the Coverdale-Murphy Act. And Coverdale and Murphy were 2 politicians from Georgia who died of massive strokes. And so Senate Bill 549 was named after both of them as the Coverdale-Murphy Act. We've got in Rhode Island the Stroke Prevention and Treatment Act. Florida has the Certified Stroke Center Law. Illinois has the Primary Stroke Center Act. New Jersey has the Stroke Center Act, and so on and so forth. These are the states where there is actually either enacted legislation or non-legislative administrative policies redirecting EMS agencies on where they should be taking stroke patients to. And these are the states in yellow. There are a total of 16 of them, and if you're from one of these states, what this means is that these state legislators and senators have passed laws or passed bills in their state legislatures and senates with regard to stroke care, but it's more about raising awareness on cardiovascular disease and stroke. So they've passed a very generic bill to raise awareness on stroke signs and symptoms, chest pain, heart attack signs and symptoms, but they haven't gone the next step in empowering EMS agencies to bring patients to the right facility, or mandating that hospitals that need to be involved in stroke care need to either decide if they want to get certified or not get involved in stroke care, because the last thing we want to do is we have all these innovative technologies and therapies that are coming out, and patients are taken to the wrong hospital and the time window is lost in those facilities. I want to move on to stroke certification and the statewide differences. I want to begin by saying that how do you get certified? So there are 4 methods how any state can get certified. Number 1, we have Joint Commission that is involved in certification. We're very happy to have Dr. Castillo represent the Joint Commission over here in the audience, and you'll hear from him shortly. We've got DNV Healthcare that provides certification, and we're very fortunate to have Kathy and Mary Margaret from DNV in our audience who will be talking about DNV later this morning. We also have HFAP, Hospital Facilities Accreditation Program, that's involved in certification, and we're fortunate to have Teres Boland in the audience who will be giving a talk later this morning. And lastly, there are a few states that don't believe in third-party certifying bodies, and they have their own self-certification options, and I'll mention which states those are. If you take the Joint Commission, and if you look at where does Joint Commission have primary stroke centers certified in the United States, it's virtually every state in the United States except the state of Massachusetts, which believes in self-certification. So if you're in one of these states and you're looking to get certified as a primary stroke center, then this is a good map to know what the lay of the land is. There are 1,049 certified primary stroke centers by Joint Commission, except in the state of Massachusetts. With regard to comprehensive stroke centers, if you are looking at one of your facilities to get certified, these are the states in which Joint Commission has certified comprehensive stroke centers as of November 1st, 2014. And there are 78 certified comprehensive stroke centers by the Joint Commission. Moving on to DNV, there are 87 certified primary stroke centers in 23 states. As you can see, there's a significant spread, widespread across the United States where DNV offers primary stroke center certification. And this is a huge asset to a lot of states where there is a huge unmet need to grow stroke centers. So I'm very pleased to see the growth of other certifying bodies to partner together to meet the unmet need. With regard to comprehensive stroke centers, we have 14 certified comprehensive stroke centers in 5 states. And these are the states, and I know that it's growing across the country. With regard to HFAP, Hospital Facilities Accreditation Program, they've got 40 certified primary stroke centers in 12 states. And with regard to comprehensive stroke centers, they have 1 comprehensive stroke center in Ohio. And the reason I wanted to share this is as you'll go back to your respective states and you want to understand what the lay of the land is, it's very important to understand whether your state has enacted legislation in favor of stroke designation and empowering EMS triaging, and which certifying bodies are allowed to certify in your states, or has there been precedent. And that's very important to avoid a lot of missteps and being able to get to market and be able to get to a certified stroke center quickly. These are the states in which self-certification for primary stroke centers is accepted. That's New Jersey, New York, Massachusetts, and Florida. There are 211 state-certified stroke centers in these 4 states. For those who are interested in finding more details, this presentation will be emailed to all of you or available for every one of you so you have the source and the references. This is what Massachusetts has done. They're the only state that does things differently. And these are 70 designated primary stroke centers in the state of Massachusetts. They are based on regions, and they've tried to geographically cover all their regions with stroke centers so that there is geographic access and patients have the nearest facility that they could go to. States that have allowed self-certification for comprehensive stroke centers, Texas used to be one of these states, but they've moved away from that. We still have Florida and New Jersey, and we have 43 state-certified comprehensive stroke centers in these 2 states. And this is an example in the state of Florida, wherein this is an affidavit, wherein the CEO of the hospital will need to fill this out and attest to the fact that they meet all the criteria for a primary stroke center or a comprehensive stroke center, and it's a self-certification method. Lastly, I want to wrap up this talk with a few lessons learned from heart attack care. You know, we've got chest pain centers, heart failure centers, primary stroke centers, comprehensive stroke centers. The terminology can be overwhelming. So I thought I'll just take a step back and figure out how this correlates with heart attacks. So you've got an ambulance, and they've got to decide whether the patient has a heart attack or a brain attack. And there are 2 options with treatments. There's either drugs or there's devices. In heart attack care, you have IV fibrinolysis, which is how it started off with streptokinase years ago and moved on to primary coronary intervention. So you've got non-PCI capable hospitals and you have primary coronary intervention capable hospitals. Similarly, in brain attacks, you have primary stroke centers that can provide drug, IV TPA, for patients with blockage type strokes. And you have comprehensive stroke centers that can be involved in both ischemic and hemorrhagic stroke, with clot retrieval for ischemic strokes and with surgical clipping, endovascular coiling, and flow diversion for patients with aneurysms. Now, if we look at interventional cardiology and where they are, we've got around 5,500 interventional cardiologists in the US. I just want to make a point over here that if you look at the number of STEMIs, or ST elevation MIs, the massive heart attacks in the United States, they're around 275,000, approximately 30% of all myocardial infarctions. If you look at major brain attacks or large vessel occlusions, we don't have an acronym like STEMIs that's caught on yet, but we call it LVOs, and they are around 46% of all of ischemic strokes if you take the stop stroke study data, and that equates to around 318,000 plus large vessel occlusions. Now you've got 5,500 interventional cardiologists for 275,000 STEMIs, and we're probably in the most liberal estimates, around 900 neurointerventionalists, all disciplines put together, for around 300 plus thousand large vessel occlusions. Now, obviously, the reason for this is that we're learning from heart attack care. We need to operationally scale up like heart attack care. We need to understand the lessons learned from STEMIs, but also we need to empower stroke centers, certify the right centers, empower our state legislatures and senators, pass the right legislations so that the right patients can come to the right facility in time, so that as much of those 300,000 patients can actually be treated with cutting-edge therapies. Now, brain attack care is a team sport. It doesn't start with the EMS and stop with the EMS, and it doesn't start with an interventionalist and stop with an interventionalist. There is an inflow of EMS and ED physicians that need to be empowered. There's an in-hospital process with neuroscience specialties and administration, which is very important to have health system administrators on board and feeling empowered as a stroke champion. And then you have the outflow system with ICUs, hospital services, and rehab. And all of these need to work in harmony so that stroke care can be provided. And this is my final two slides. I just want to share and thank my clinical team at the Texas Stroke Institute that's been involved in a lot of work. We have 122 hospitals that we are created a large regional network. This is our administrative team. And this is how we started in 2008 with 5 certified level 2 primary stroke centers. And then we grew on to creating all of them as primary stroke centers, geographically selecting an eastern hub and a western hub as a comprehensive stroke center, and then having a northern hub and then a southern hub. So we're the first health system in the United States to have a certified comprehensive stroke center in all 4 cardinal directions to be able to meet a larger geography. And we see around 4,000 stroke patients and are able to touch on close to 122 hospitals. And the reason I wanted to share this is it is really a team sport at the end of the day. So thank you for the time. And if there are any questions, I'd be happy to answer. Otherwise, at the end of the session, we've got some great speakers lined up. Thank you again for the attention. In the interest of time, we'll probably move on to our next speaker. I'd like to introduce, can we have the next talk, please? I'd like to introduce Dr. Alex Venizelos. He's a neurocritical care trained physician, as well as has a passion for neurointervention and stroke intervention. It gives me great pride to introduce Dr. Venizelos, and he's going to talk about why is stroke certification needed, what is the clinical impact that stroke centers do, as health systems explore the possibility of certifying. Dr. Venizelos.
Thank you so much. Thank you for being here. I'm excited to be talking on behalf of Texas Stroke Institute regarding stroke center certification and the clinical impact. This is really important, and for several personal and professional reasons. I've gotten involved in the triaging the stroke system, and we've done a lot of work at our institution, and there's a lot of publications I wanted to share with you regarding the stroke system of care and how it ties into stroke center certification and designation, and how that affects patient outcomes. So thank you for being here. I wanted to start with, can you go back one slide, please? Start with the idea that systems of care save lives, all right? This is something that we've seen time and time again, whether it's STEMI, cardiac arrest, trauma, whether it's Ebola, screening, triage, and transport, or even rounding in the ICU. It's the algorithmic, systematic organization of seeing patients, a checklist, so to speak, such that we know patients are safe and meeting certain criteria, certain checkpoints every single time. Of course, there are times we need to divert from that algorithm. Every patient is specific, every patient is important and different. However, it's these systems that have been proven time and time again to save lives, to improve patient outcomes. And that's what we're focusing on today, and focusing on more and more in stroke. These are the components of stroke systems of care, and as you can see, it involves not only what we do inside the hospital, but it starts in primary prevention. It starts with the patient seeing a primary care physician, being screened for cardiovascular risk factors, stopping smoking, and then also public awareness and community education about stroke. We're not lucky enough to have pain as one of our cardinal features in diagnosis and presentation, so patients oftentimes go back to sleep. They think no big deal, it'll go away, and they don't come to the hospital. So it's important to let people know that not only is this an important diagnosis, not only is it a significant diagnosis, but it's also time sensitive. And we have to know to call 911 to activate the system so that they can come to where they need to be. All these strokes are no good to anybody if we can't see them in a timely fashion and treat them appropriately. Moving on to 911, so patients know that something's wrong, they call 911. Now it's important to take them from where they are and put them to where they need to be in a timely fashion. And this is a more complicated process, something that we're working on every day, improving. 911 activation, emergency medical dispatch, followed by pre-hospital triage and activation, and how that affects the system is exceedingly important. And then to where we are, where most of us here in this room are on a daily basis, that's in the hospital. Once patients get there, they have to be screened, imaged, labs drawn, vitals taken, assessed for the appropriateness for either intravenous thrombolytics or PCI, and then admission to a critical care unit if that is necessary, followed by a telemetry unit or specialized neurocritical care floor, counseling on cardiovascular risk factors, screening for cardiovascular risk factors, and then, in my opinion, the most important stage of patient treatment, and that's the reintroduction into society, because we're not doing these things just to have a job, just to do them for fun. We're trying to reintroduce patients back to their lives, back to their families, and back to their work as productive members of society. So this whole system is important to think about as we talk about the clinical impact of stroke center certification. And even though we're talking about the inpatient portion of stroke center certification, it really affects, and if you look at the different, we're going to talk about the different components of certification, it involves every step along this continuum of care, and I think that's the most important thing to consider as we move on today. It's not just the certification of a primary comprehensive stroke-ready hospital, it's really how it affects the entire system. Designation and certification, all these terms have been flying around all morning, and I think that there's some clarity that's coming up, but it's an essential building block of stroke systems. What it does is it focuses on the individual hospital, it affects public policy, it affects public health, and it demonstrates a commitment to disease-specific certification. To say that, yes, this is something I recognize, this is something that's important, this is something that we are going to try to improve upon is very important in coming together and building a comprehensive stroke system. And certification, and I think this is what we're talking about today, is more than just designation. So anybody can say, hey, I'm really good at something, or they're really good at something, or they should do something. But once there's a process, once there's an algorithm that says, okay, you can do that if you do this, this, and this, that's when certification becomes certification and not just designation. So these are the clinical points I'm going to touch on. I'm going to bring up a couple studies, both from the Texas Stroke Institute and around, that talk about quality and performance improvement. I'm going to talk about research, scholarship, and teaching, how that's affected, and integration along the continuum of care. And these are the three most important clinical components of certification in stroke as it affects the system of stroke. So this is a study done by the American Heart Association in JACO primary stroke centers. And what they saw is that there's been an increased rate of thrombolysis in certified stroke centers. So this is just an example of how that certification process not only highlights what's important, but also leads to increased rates of treatment. This is a study that we did at the Texas Stroke Institute, looking at the rate of thrombolysis in our system. This is after we introduced the comprehensive stroke centers, the primary stroke centers, and the triaging system that we use within our system. And we hit double-digit treatment rates in ischemic stroke. And not only increased rates of thrombolysis, but also increased stroke volume. This touches not only on the recognition of EMS, bringing patients to appropriate hospitals, but also community outreach, going in and talking to patients, talking to physicians about stroke awareness and stroke care has led to an increase in the number of patients that are presenting for disease within our region. So this is something that I think is very important, leading to what is above and beyond the most important component of quality improvement. Hey, we treated a lot of strokes, there was a lot of TPA given, we use it like water, but when it really matters is when it affects patient care. So this is a study that we did comparing data from 2010, which was prior to the full implementation of our stroke system, to 2012. And we have shades of green there in the bottom pie charts that represent a good discharge disposition. We qualify those as a discharge to home, discharge to home with outpatient physical therapy, or discharge to an acute inpatient rehab. And we saw a statistically significant difference in the percentage of patients who were discharged to those three facilities. Now the purple is patients who were discharged to a skilled nursing facility. The black are patients, unfortunately, who passed away. The red was triaged to another facility or left against medical advice. So not only are we seeing more patients, not only are more patients coming to the hospital, not only are more patients being treated, but patients are actually benefiting from all these measures that we're taking into account. And certification really lends itself to concentrate, to highlight those important factors. These are some examples of outreach and scholarship and teaching that we do to educate our community. We have several news spots with different members of our team talking about disease-specific considerations. That's a news story on top. We've been participating in several nationwide meetings over the past several years, presenting abstracts, posters, developing manuscripts. And then the bottom right picture is and actually that middle picture there, they're from our neuroscience symposium. So we put on a third annual neuroscience symposium to teach our colleagues, to teach primary care physicians in rural communities, nurses, physical therapists about neurovascular care and how what we do matters and how to improve it in your system. So it's not just about your own hospital being certified. What you need to do is also reach out to those other communities, which is important in certification. And then lastly, the integration across the continuum of care. Now this is an abstract that's being presented this week by Sharon Eberlein and her partners at Plaza Medical Center, where they've started an initiative to draw labs from the pre-hospital arena. So actually the ambulance draws labs, starts those labs cooking, gives them to the hospital so they can expedite treatment. And they brought, you see the yellow versus the blue, is the pre-hospital lab draws, the yellow is the labs drawn in hospital, and you do see a statistically significant difference in the treatment times, the door-to-needle times for those patients, and you guys can view this poster this week. There are several papers describing the implementation of stroke systems and how it affects patient treatment. This is from Chicago, where I did most of my residency and fellowship training, showing increased rates of thrombolysis in the city of Chicago and surrounding areas after the implementation of the stroke systems that we're talking about. And this includes certification, designation, and then these coordinated EMS, fire department, medical director movements to organize triaging of patients to appropriate centers. Similar thing was seen in Toronto and several other cities across the nation. And these are just two of the biggest studies that have been published about the increased rates of thrombolysis after the implementation of these systems. And then again, looking at the outcome, the clinical outcome of patients is also important. This is a Portuguese study that talks about the improved mortality after the development of these systems. So that is all the time I'm going to spend today talking about the clinical impact of stroke center certification. I hope it's a little bit more clear how what we do and all these complicated terms and all the work that we do to certify ourselves, to designate ourselves, how it affects the entire community. And they're not tireless efforts. They're efforts that actually translate into real clinical outcomes. So thank you so much. Yes, sir.
Thank you, very nice talk. Can you share with us how do you get that data of the outcome? Is it the Medicare data or the state data that you collect?
So they were, so our system is healthcare HCA. It's a hospital system, and within the Dallas-Fort Worth area, it's all driven by diagnosis codes, and every single patient that's admitted with a primary diagnosis or secondary diagnosis of ischemic or hemorrhagic stroke was what we looked at. And then all that data is collected, and then we looked at the discharge dispositions specifically for those patients, which were all recorded. So it's all kind of retrospective analytic data based on patient primary and secondary diagnoses.